Now we're going to cover an example of ultrasound video transmission of an atherosclerotic plaque, shown right here, in a communications channel where you have 15% drops of the packets. In other words, 15% of the packets being communicated in this wireless channel do not make it. Only 85% get through. And this is typical of a wireless network, okay, that you will drop some. Okay. This example, we are using H.264, and we're demonstrating some of the new technologies developed at UNM in collaboration with the University of Cyprus and Imperial. And here we have, notice how we have flexible macroblock ordering is new technology for H.264, and it requires 682 kilobits per second, which is relatively high bandwidth, as opposed to the methodology that we will show that we have developed that drops it to 50% less and only 274 kilobits per second, and also will perform much better than the original H.264. As you will see here, the plaque will disappear right there. And this happened because there was no error recovery in this original encoding. Let me repeat this. As you could see, there are some artifacts everywhere, but most importantly, you have lost the plaque, and the errors appear randomly everywhere. In the proposed approach, we will demonstrate right here, we use what is called redundant slices, extra slices, to protect essentially allow the system to recover from the dropped pieces. So as you can see in our example, we are not losing any information, and the physician will be able to see the plaque and the stenosis, and therefore the video remains useful despite the problems in the network. Okay. More recently, and this is a paper published in the Signal Processing magazine last year, IEEE, one of the best journals in this area, we're showing the great promise of a brand new system, video coding system. It's called the HEVC, High Efficiency Video Coding, that will become the standard in the next 10 years. We've been working with early versions of this system. Okay. So here we have the savings of the new system, HEVC, over what is currently being used. Most hospitals and the original DVD players are based on MPEG-2, and there's a 70% reduction in storage requirements over MPEG-2. Some relatively more modern standard of this century, the MPEG-4, and you can see that even MPEG-4 is you can have significant reductions with the new standard with HEVC. And then over here on the iPhone side, you can get 35 to 40% with the very latest mobile devices that, assuming they're using state-of-the-art H.264 encoding. So this new standard promises, here tested with 10 videos, which were running at 50 frames per second, promises to save a lot. And here at UNM, we looked at the completely new video compression systems that are based on what we call drastic. So we have taken a rather dramatic approach to video compression, where instead of just the standard classical video compression of looking at compressing the entire video in a certain way, we want to be able to adjust the video compression mode to provide the users with options that provide quality in many different environments. So let me talk a little bit about this. We're talking about dynamically reconfigurable systems. Dynamically reconfigurable meaning that we allow the hardware and software to change. This is completely new because we are looking at computers that really rewire their own hardware. In other words, they really are able to become different computers inside in hardware. They will have more multipliers, more adders, or more hardware, as I demonstrate, to perform better. And then they're allowing themselves to turn those pieces off or to save power. So we have 4 different modes that we consider. Number 1 is, very interestingly, the minimum power mode. You can imagine if you're using a mobile device and your battery life is not significant and you still want to, let's say, the doctor to communicate with the patients, then in the minimum power mode, you allow the system to conserve power. Don't consume very much. You're minimizing that, while still you maintain a level of quality that makes diagnosis possible. And the bit rate here, in other words, the bandwidth, stays within the bounds of your network. Okay? So we have this minimum power mode that the users will be able to switch to save power. Another one is what's called the minimum bitrate mode, which essentially tries to compress for the minimum amount of required bandwidth. If you can imagine in a situation where there isn't that much bandwidth, then you really want to be able to minimize your bandwidth requirement, because otherwise you won't be able to communicate, again, subject to constraints on the quality. The next one is, of course, you also want to, similarly, if you have many users or you're looking at, doctors looking at multiple videos at the same time, you want to minimize the bit rate for, let's say, cases that have already been reviewed and you're just running in the background. Okay, another one is like when at the beginning of an exam, the doctor will want to have what is called a maximum image quality mode. Here, you really want to allocate the best quality of your video because you're doing an initial review and you really want to see all the possible things that went wrong. This is a maximum quality mode that within reasonable power and the available bandwidth, you try to provide the very, very best quality. And then a typical mode that tries to balance all of them. And as I said earlier, our research here allows you to switch between those different modes. The user will be able to change how they encode their video. Here an example of applying these ideas to what is called a discrete cosine transform, the DCT. DCT is the fundamental component that is in every image and video compression today, including JPEG, MPEG standards H.264 and the new HEVC. What we have done is that we have this called dynamic hardware block that essentially changes the hardware. It changes the transformation. It really internally inside the computer. We allow it to have more multipliers, more adders, to perform larger transformations, or smaller. In addition to allowing the users to change the quantization, which is done in software, right? So this is really innovative research. What we're looking at is we adjust the software and the hardware as opposed to just changing the software, the programs. And this really has the effect of allowing the users to control the different modes. Okay. More recently, we're doing work with HEVC, which involves this complicated system diagram that I won't go into. In here, we have different predictions. We have implemented, for example, all of the different directions and the different sizes of the blocks that the video has been broken into. Okay. One very important example here is notice that we're demonstrating on a standard video. Unlike the standard video compression that allows you to operate at a single point, we have all these beautiful surfaces. You'll see these different points where the user can apply the drastic modes. For example, here the PSNR measures image quality, so the user can select higher quality, or if they want to play the video at a higher frame rate, they can select it here, and based on the available bandwidth, the hope is that the user will have a solution along the surface. Of course, You can change the time by changing the hardware and by a more advanced computer, or if, for example, if you want to encode for particular different rates. So this joint, all of these points show an example of what the user can do under drastic. Okay. Another way to look at it, let's say after when the doctor is unavailable, or if the bandwidth is unavailable, you can do the analysis locally at the emergency scene, right? So here we have very recent research that we are doing where the computer, in the absence of a doctor, tries to help the diagnosis by doing it locally. In other words, computer software has been trained with the help of the doctors to provide the diagnosis on the fly without the need for communication. So it's a completely different approach where if the communication bandwidth is not there, then we want a computer to help us analyze the motion. In this case, users can help locate the plug on the video, which is then estimated, the motion is estimated, and then we want to essentially tell the users, in this case emergency technicians, what we think about the patient, right? Here's a really nice example showing you that this is an example of a very stable plaque because most of the motions are concentrated in this blue region. This work with the Imperial College Professor Nikolaidis classifies the videos as concordant plaques and discordant plaques. And basically, here we have a very dangerous case because the motions are everywhere. Notice those little green arrows here computed by our system. And the system also computes these graphics here that show that we have a dangerous case, right, versus a case here where your motion is pretty solid. Okay? In this case, we're looking at statistics over the entire video. These are computed little point captures the median velocity over different frames. And we have this scatter plot. These are the patients that are more or less stable and far less critical to transport to the hospital in terms of the plaque. In this case, the motions are concentrated to the left. These are dangerous cases where, as you can see, there are very dangerous motions, extreme points that occur here at 6 pixels, 5 pixels down to 2. And as you shall see, the computer tries to classify the case based on these points here. In this case, pixel motion of 5 down to 2. So by adding them up, you can see very nice separation. Here is relatively limited motion for more stable patients versus a high-risk case that has statistics that are more dangerous in this total sum, showing significantly more motion. And we're able to do that. This was tested for 35 cases where we had 13 discordant, which are difficult cases, versus concordant. Okay? And the computer was able to tell that these were dangerous cases. Another way to do the analysis locally is to essentially analyze a single image. This is work that was done by Professor Mare, who is right now in Lima, Peru at UTEC. And we hope to also have more work in this area. In this case, during his PhD, Professor Mare, he worked on the MFM texture analysis methods. And in his case, he was able, you extract information, you encode the image information using what is called MFM analysis methods. These are features that human eye cannot normally see, but they are very useful for the computer. And a computer software called classifier takes what was been extracted and tries to make a diagnosis out of it. We looked at many systems here. The one that we're going to show is the one based on retinal image analysis, where the goal is to screen the entire population beyond a certain age, we want to avoid people from going blind. So the hope is to screen for diabetic retinopathy. These kind of technologies are being investigated for plaques. And then, of course, we've seen an application in multiple sclerosis where we could find evidence in this analysis of very dangerous lesions versus lesions that are not so dangerous. And this type of classification cannot be done by human, but by collecting the images in time, we could find that evidence earlier. It's been applied to cancer, gynecological cancer, but also more recently also in mammography. Here's an example for Dr. Murray. This is a retinal image. This is the original picture that, although it's been analyzed by humans in its current form using these AM/FM techniques, computer turns that into binary formation of different extractions. For example, as you can see over here, these white pixels were colored to show where blood vessels are there and analyzing their structure. Notice how the computer decomposition produces many different images, extracting different versions, and then they're used to classify. So this is the final output, showing you a great promise of the system. In this case, we have 4 plots. The ideal system, the one that never gets anything wrong, will approximate 100%, and most doctors will not even be able to get there. But as you can see here, case after case, computer analysis is in great agreement with the doctors. In this case, we have risk 0 meaning normal, 1 is early stages of disease, 2 is higher, and 3 are the most advanced cases. And computer was asked to classify, let's say, normal versus abnormal or early abnormal cases, and you can have excellent results where you get all the abnormal cases, but sometimes it's been classified, some of them as abnormal where they were normal, and 82% there, the specificity, those require extra exams. So notice that the high sensitivity means that the system is trying to be conservative, identify all of the abnormals while still allowing misclassification of some normals, and extra exam will show for the some low percentages of normals that were misclassified will clear them. Okay. More recently, we're working on what is called big data. Big data comes very naturally in medicine, especially in what we call video database communications, which are very large-scale databases in most hospitals that store videos. Obviously, based on what we said before, these video databases need to be communicated, and they need to maintain a very high clinical video quality. Otherwise, there's no reason to even store them, right? And we want to allow the users to review the videos based on drastic, like have high quality modes, but also like lower bandwidth modes in case that a doctor is in a region without too much power or bandwidth. So we want to transmit anywhere and pretty much any time. I mean, you need to be able to review them on both very small and very large devices. So anywhere, anytime, big data sets, communications is what we're working on right now. Finally, I would like to thank Dr. Yubing Zhang, completing his PhD at UNM here May 2014. He produced the original drastic modes. Hamed Nazrabadi worked on the motion estimation that we showed earlier. Gangahara Mesaki and Vengares Chadla are working on the big data concept. The ultrasound videos that were used were provided in collaborations with Professor Konstantinos Patihis from the University of Cyprus, Andreas Panagidis, and Professor Nikolaidis from Imperial. And then the diabetic retinopathy example was done by Professor Murray, who is now at UTech in Lima. Thank you.